I think this is a great question. When and why do you order coags? Because I think, if anything, we order it too often. And I think it's important to remember that this is often the blue tube that you need to fill up all the way to the top, which is also the most annoying one to fill if you have a hard stick patient. And if a tech or a nurse or a phlebotomist or whoever comes to you and they're like, oh, they said that they couldn't get enough for the coags. And if you say, I didn't really care about it too much, we don't have to redraw it, you probably shouldn't have drawn it or ordered it in the first place. Let's say you have a patient on warfarin, which inhibits vitamin K epoxide reductase. And this is nerd speak, but hang with me here. Let's say you're trying to improve your healthy habits. You eat a bunch of kale. Kale is high in vitamin K. If you have way too much vitamin K, you're able to circumvent the bottleneck created by warfarin, the vitamin K epoxide reductase. Meaning that your vitamin K is able to gamma carboxylate or whatever the factors 2, 7, 9, and 10, which are the coagulation factors that are made in the liver. Or said more briefly, more vitamin K, more clotting factors, INR is lower. If I have a patient who is on warfarin and I'm worried about a DVT or a PE, you get coagulation studies. But the reason for that, in the history, if they give you, I've been eating a lot differently, they could be more thrombotic. On the other hand of that, if you have someone on warfarin and they're bleedy for traumatic reasons or even for no traumatic reasons, they have spontaneous bleeding, they brush their teeth and there's a bunch of bleeding, they haven't touched a vegetable, they don't even know what kale is in the past 10 years, you check the coag, their INR is 10. That could be why. People like to often say as well, get coags if you think they're going to go to surgery or an urgent procedure, which I think is fair as well, right? Like someone's not going to take someone for an appendectomy if they don't know if their INR is 1 or 10, reasonably so. But I think it can be short-sighted at times if you're like, maybe they could go to surgery. Technically anyone can go to surgery, but you don't need to upfront get coags. Any belly pain in a child could be appendicitis or ovarian or testicular torsion, but I don't preemptively get coags on that patient. If you have someone with liver failure, that could be another reason to get coags as well, because that could be more concerning for acute liver failure than elevated LFTs. I talked about LFTs in this past video. Sometimes I think about LFTs as this marker of inflammation or something going wrong, but if you don't have any transamp2-itis and cirrhosis, your LFTs could be normal, but you could be floridly bleedy with a high INR and normal LFTs. And if that doesn't make intuitive sense, you could think of your average CrossFit athlete who has rhabdomyolysis could have a CK of 15,000, get some fluids for a day or two and go home. A 90-pound grandma who was on the ground for 5 days could also have rhabdo, but their CK could be much less impressive because they have less muscle to break down. So those are a couple things I think about.